Welcome to your articulate module on disorders of the upper extremity. I hope you enjoy your module, go through it at your leisure, and please go through this module before you come to your clinical correlates lecture of the upper extremity. I think this module will prepare you well for that. There are many topics that we will cover in this module, but your main objective with each topic is to first identify these as the most common musculoskeletal conditions and injuries of the upper limb.
As I was talking about ordering pizza today, and then when you're done...
Of these injuries, the clinical characteristics, patient presentation, and evaluation of these injuries, understand the treatment principles, and then understand the ramifications of these injuries, and in particular the ramifications of missing these injuries. For each condition, I want you to think about and understand how the age and activity level of the patient truly directs your treatment. It affects the pathology of the injury, why it occurs, and then it directs your treatment plan. Take a minute and read through this slide. These are the conditions of the upper extremity that we'll cover in this articulate. Some, as you'll see, we'll cover in more depth than others, and that really reflects the importance of these conditions. So take a minute and read through, and then we'll get started. This engaged interaction is a brief overview of the most common musculoskeletal conditions and injuries of the upper extremity. Essentially, these are the topics that we're going to go over in this articulate. Each tab to the left is a brief overview about the key points of each condition and lets you know what we'll be discussing in depth with each condition. Take a minute and look through this. Note, you can really divide up this articulate so you don't have to spend too much time all at once. Everything is grouped into the different topics, so you can pick today I'll do 2 topics, tomorrow I'll do another, but take your time as you go through it. Know that for each condition, as I stated, we're going to go over more in depth and differentiate the etiology, the clinical characteristics, the patient evaluation, the treatment principles, and the ramifications of each injury. This Engage interaction is a flip book. It's on a big topic, the rotator cuff. We spend so much time on the rotator cuff because it really is one of the most prevalent conditions that you will see people with shoulder pain for in your clinic, in the emergency room, and in primary care offices someday. The rotator cuff is a big topic. What I like about this flip book and what I like about this topic and this Engage interaction is that we're really going to tie in your anatomy, your dissection in the lab. We're going to tie this into physical exam, patient history, how to evaluate, go through the natural history of the rotator cuff, imaging of the rotator cuff, and tie a lot of the pieces of this course together. Take your time and read through this and pay particular attention to the summary slide, which really sums up what I feel is the most important for you to know about the rotator cuff, in addition to the fact that we expect you to know your anatomy, your origins, your insertions, your functions, and your innervation of the rotator cuff muscles. So sit back and relax and enjoy your ride through the rotator cuff. This slide is just a view for you to look at an MRI image of an acute rotator cuff tear. It is a coronal view of the shoulder. The cut is right through the glenohumeral joint, and it is a fat-suppressed T2 weighted MRI. So remember, water is white on a T2 weighted MRI. The white arrow is on the edge of the supraspinatus tendon. The tendon is black and it is torn off of the greater tuberosity. Remember the insertion of the supraspinatus tendon. You see the muscle belly to the right of the arrow, and the tendon should be inserting to the left of the arrow on the greater tuberosity. It has acutely torn off, and this is about a 2 to 3 centimeter acute rotator cuff tear. But note, I'm never going to ask you on a test to look at an MRI and tell me whether it's acute or chronic, unless I'm having you look at muscle belly and you see extreme atrophy in muscle belly of the rotator cuff muscles. You know that atrophy does not happen acutely, so when you see atrophy of any of the rotator cuff muscles, you know that's a chronic tear. But again, I'm not going to have you read atrophy off of an MRI, but you should know that concept. Now this is a similar image of the glenohumeral joint. It's another fat-suppressed T2 weighted coronal MRI. Here we see a chronic retracted supraspinatus tear. So the top red arrow is on the retracted supraspinatus tendon. See that the tendon is actually medial to the glenohumeral joint. So that's about 7 centimeters away from its insertion on the greater tuberosity. And then the bottom arrow is on the supraspinatus muscle belly. You can't really see well on this MRI, but that muscle belly is atrophied. So we know when we put everything together that this is a chronic retracted tear. In this engaged interaction, we'll go over injuries to the biceps tendon. Injuries to the proximal and distal biceps tendon are actually pretty common, and a lot of people do sustain injuries to these over the course of their life. This engage will go through first your anatomy. Remember, we've always got to start with the anatomy, the origin, insertion, and innervation of the muscles we're talking about. But then we'll talk about the etiology and the clinical characteristics, how we evaluate these patients, and the treatment principles and ramifications, because it really is quite different how we address long head of the biceps or proximal biceps tears versus distal biceps tears. So take your time and go through this engage and enjoy. Take a minute here and refresh your memory of your biceps anatomy and overall the anterior anatomy of the arm. This engaged interaction will go over injuries to the pec major. We really almost exclusively see injuries to the pec major in people who are bench pressing and doing heavy lifting and heavy workouts. So really we rarely see this injury in women. It's a nice short little engaged interaction. Take a few minutes and go through it. Most important, review your anatomy of the pec major, the innervation, and take a few minutes to understand the etiology and treatment of this condition. Injuries to the AC joint are pretty common. We see them a lot in musculoskeletal medicine. Take a few minutes and go through this articulate. What's good about this engaged interaction is that we review your anatomy, but this is going to tie into your ligament histology. You're going to think about your ligament injury, your ligament healing lectures and articulates, and it really ties everything together nicely. So look through this and learn a little bit about how we treat AC joint injuries. This slide just reviews the anatomy nicely for you of the AC joint. The picture on the left is actually an anatomical dissection showing the conoid and trapezoid, which remember give you vertical stability to the clavicle, and shows the AC joint. You also see the coracoacromial ligament, one of the other ligaments that goes from the coracoid to the acromion. However, remember the coracoacromial ligament is not involved in the stability of the coracoclavicular joint. The picture on the right is what we classically see in a type 3 AC joint separation. All the ligaments are torn or ruptured, the AC and the CC ligaments. You might hear, if you do more in-depth reading on AC joint injuries, that we have up to 7 different grades of AC joint injuries. These are just different configurations of the clavicle when all the ligaments are torn. We don't expect you to know any of these configurations. We do want you to know that if all the ligaments are torn, that is a grade 3 separation. Remember from your ligament injury lecture or articulate, if the ligaments are torn, it is always a grade 3 injury. Shoulder instability is a pretty big topic. Take some time and go through this module or engage interaction. Of course, you always need to review your anatomy to understand shoulder instability and shoulder dislocations. Some of the main takeaway points, though, after you review your anatomy, is understanding that shoulders dislocate in different directions, and that is related to the different mechanisms of injury. Know that young people with shoulder dislocations are treated very differently than older people with shoulder dislocations. The type of injuries that occur are different with a young patient versus an older patient, and our treatment principles and the ramifications of the injury are different for young versus old patients. And of course, one of the most important take-home points is that we can't have you miss a shoulder dislocation someday. That unfortunately is commonly occurring in emergency rooms and a big source of litigation. Therefore, take some time and go through this and learn about shoulder instability. This slide reviews for you the anatomy of a normal shoulder. It is a sagittal view of the shoulder. The humeral head is subtracted and you're looking straight in on the glenoid. Take a minute and look through this. This diagram is a drawing of a Bankart lesion. Remember, the Bankart lesion is the common lesion that occurs in young patients with a traumatic anterior shoulder dislocation. It is a tear of the anterior inferior labrum. The blue area is on the torn labral tear. Pick out the coracoid to the left of the blue arrow. That lets you know that that is anterior. Therefore, you can understand that the labral tear is anterior inferior in the Bankart lesion. Just a brief note on physical examination after a dislocation. We'll go over this in your small group session. But remember, in the older patient, you must assure their rotator cuff is okay after a dislocation. So you must perform rotator cuff testing. And again, we'll go over this in your small groups. For young people, very unusual to have a rotator cuff tear. Young patients have a labral tear, and their issue is typically recurrent instability. So we'll review here the apprehension test. And again, you'll go over it in small. First, this slide reviews the standard lift-off test. You'll review this in your physical exam video. The lift-off test isolates the subscapularis. Remember, in older patients who have a dislocation, they can often tear their rotator cuff, and this is often when a subscapularis tear can occur. So the subscapularis is solely responsible for lifting your hand off your back, so this is how we assess if the subscapularis is intact or not. The belly press exam is another way to test for subscapularis integrity. This will be reviewed in your small group and in your physical exam video as well, but sometimes it hurts too much for the patient to put their hand behind their back for the liftoff, so the belly press is a good way to check the subscapularis because we do not want to miss a subscapularis tear. Now for the younger patients, as I stated earlier, the apprehension test is really what we're checking for recurrent instability. This is the main test that you should know and carry into clinical practice. Of course, there are a lot of very detailed instability testing that more musculoskeletal specialists know. But for you, you place their arm in the position of risk, abduction and external rotation, and you ask the patient if they're apprehensive, and they often will tell you, oh, I'm worried, I feel like my shoulder is about to dislocate, and this would be concerning for anterior instability. The relocation test is the next step after the apprehension test because essentially the patient is nervous and worried their shoulder is about to dislocate anteriorly. When you put your hand there and you give a posterior pressure on the humeral head, they'll be relieved and say, ah, that feels much better. That's a positive relocation test. Now we'll just review some x-rays and the importance of proper x-rays for evaluating dislocations. On the left is an AP. On the right is a scapular lateral view of the shoulder. Take a minute and look through this and think about what you see. So I'm sure you thought on those prior films that it really wasn't clear exactly what was going on. So you do the right thing and you get an axillary view. So look at this axillary view of the shoulder. First, find your landmarks, and then you can see the coracoid. You see the glenoid. There is no humeral head articulating with the glenoid. The curvature of the humeral head is posteriorly dislocated and overlapped posteriorly with the scapular spine. So this is a posterior dislocation that you're really only picking up because you got a good axillary view. Okay, so now we look a little more in depth at that AP view I showed you 2 slides back. Take a minute and read through this slide. Now I show you the same axillary view again with all the landmarks pointed out. Don't worry, after a while you'll get very good at looking at these axillary views, and remember, if you get this view, you are not going to miss a dislocation. This interaction goes over glenohumeral arthritis. Note that the presentation, the physical exam, The clinical characteristics or the classic X-ray findings are pretty similar to osteoarthritis or degenerative joint disease of the other joints. And you've gone over that in your radiology primer and your radiology articulate. You've had your osteoarthritis lecture. So really we're just going over some of the unique features of arthritis to the shoulder joint. So take a minute and go through this. The next topic is lateral epicondylitis, commonly known as tennis elbow, although you'd be surprised the majority of people who have this have never played tennis. Lateral epicondylitis is basically tendinosis of the extensor carpi radialis brevis. Because the true pathology is actually tendinosis, we really see this in older patients, typically after the age of 40. Repetitive wrist activity makes the lateral arm pain worse, and they're tender at the lateral epicondyle, the origin of the ECRB. Again, the classic finding is pinpoint tenderness right at the lateral epicondyle. As with many tendons that we treat tendinosis, lateral epicondylitis treatment is really not much different. We always start with ice, anti-inflammatories, and activity modification. Physical therapy can be helpful, a counterforce brace, sometimes a cortisone injection, and often just giving it time. We typically do not rush into surgery. The theory behind the counterforce or unloader braces is they essentially take the load of firing the muscles off of the tendon, giving the tendon a chance to rest. Medial epicondylitis is a very similar pathology, but on the medial side. We call this golfer's elbow, and it is tendinosis of the pronator teres and the flexor carpi radialis. And the symptoms and the presentation are really the same, but just the opposite of lateral epicondylitis. The only one difference here is that sometimes these patients have concurrent cubital tunnel syndrome, which is irritation of the ulnar nerve, because remember, the cubital tunnel sits just posterior to the medial epicondyle. The treatment of medial epicondylitis, as you can see here, is really the exact same as the treatment of lateral epicondylitis. Take a minute and look. Next, we'll take some time and talk about compression neuropathies of the upper extremity. This is very common, and you'll see a lot of this just in friends and family and in practice someday. So compression neuropathy is dysfunction of a peripheral nerve caused by pressure. The pathophysiology, you're really going to learn a lot more in your neurology block. You'll learn a lot more about the anatomy of nerves in your subsequent blocks. But know that overall its signal conduction along the nerve is altered, and there are many different reasons why this signal conduction will be altered. On this slide, we review the general risk factors for having a compression neuropathy in the upper extremity. Look at all of these, and although these are risk factors for many people, there really is no clear reason why they have the compression neuropathy. And for these, we just say it is idiopathic. Listed here are the most common compression neuropathies of the upper extremity. Now for this articulate, we're really going to focus on the two most prevalent clinical disorders, cubital tunnel and carpal tunnel syndrome. However, as you've learned your anatomy well, you've studied your brachial plexus well, and you know the course of all of these nerves, you know the muscles that all of these nerves innervate, you should be able to think through the consequences of compression of the other listed nerves. An important concept to differentiate is high compression versus low compression. Take a minute and read through this slide, but the best thing to remember is that when there is compression of a nerve, all muscles innervated by that nerve distal to the site of compression are what are affected. So any muscles that were innervated above the site of compression will be fine and will not be affected by the compression. Carpal tunnel syndrome is certainly the most prevalent compression syndrome of the upper extremity, and it is a clinical syndrome of numbness, tingling, and a pain associated with compression of the median nerve at the wrist. Take a minute here, maybe even grab your anatomy books and diagrams of the brachial plexus and remember the origin of the median nerve. This is a great diagram that shows all of the muscles that are innervated by the median nerve and where they receive their innervation, and on the right you see the sensory distribution of the median nerve. So note, if your median nerve was out, was injured, was compressed proximally, you would not have sensation in the pink highlighted areas on the right. So a lot of people present with symptoms from carpal tunnel when their hand is in a flexed position. So with activities such as driving and reading a newspaper, their hand is flexed, there's pressure on the carpal tunnel. Also at nighttime, many people sleep in the fetal position with their wrists flexed. That puts pressure on the carpal tunnel, and that's why a lot of people complain of night symptoms. They also complain of pain, they feel weak, and they might say they're dropping things. Take a minute and remember the anatomy of the carpal tunnel. We do expect you to know the contents. So now we'll go over some of the classic signs of physical exam findings, and remember this has gone over in your hand physical exam video as well. A Tinel's test is a generalized term meaning that tapping on a nerve will reproduce symptoms of that nerve. So at the wrist, a positive Tinel's test is tapping on the median nerve of the carpal tunnel reproduces symptoms. Phelan's test is basically recreating positions where your hand is flexed, such as picture yourself reading the newspaper, driving, or sleeping curled up at night. So on physical exam, remember we always inspect. We inspect for atrophy, deformity, and skin changes. So atrophy would be really chronic carpal tunnel because that means there's been pressure on the median nerve for a long time affecting the contribution to the thenar muscles, and you'll lose the fullness of the thenar muscle. When you do sensory testing, remember the sensory distribution of the median nerve from the earlier diagram, and you'll compare one hand to the next, to the normal side essentially, to see if there's a difference in sensation. The confirmatory test, which I'm sure you're going to learn a lot more about in your neurology blocks, is a nerve conduction study and an EMG. So when we start treatment of carpal tunnel, we never rush into surgery. We start with a splint because remember flexing the wrist puts pressure on the median nerve, so if you extend the wrist, you're going to take a little pressure off the nerve. Cortisone injections are an option. They're pretty painful, but they can help calm down the inflammation and the swelling, which often is why you have pressure on the nerve. If everything fails and symptoms persist, then surgery will release the transverse carpal ligament and therefore let the nerve breathe and take pressure off the nerve. Cubital tunnel syndrome is less common than carpal tunnel. Very similar type of characteristics though, just pressure at the ulnar nerve at the elbow. So numbness, pain, and weakness associated with compression of the ulnar nerve at the elbow. Here's a similar diagram as the median nerve, showing you on the left the sensation of the ulnar nerve, and on the right all muscles innervated by the ulnar nerve and where they receive their innervation. Here's a little anatomy diagram, but just remember the ulnar nerve sits in the cubital tunnel, which is just behind the medial epicondyle. Take a minute, feel your own medial epicondyle, and then feel just behind it. That's where your ulnar nerve sits. Symptoms and exam findings are pretty similar to carpal tunnel, just in an ulnar nerve distribution. So they present with numbness and tingling. It's worse at night because elbow flexion puts more pressure on the cubital tunnel, just as wrist flexion puts more pressure on the carpal tunnel. Therefore, elbow flexion at night, or if you're reading a book, can put pressure. They also complain of pain, and they have weakness. They have a positive Tinel's at the ulnar nerve, so tapping on the ulnar nerve of the cubital tunnel reproduces the patient's numbness and tingling. And then the elbow flexion test is a lot like your Phalen's test. So maximal flexion of the elbow will put pressure on the ulnar nerve, hold the patient's elbow flexed, and they'll say, yes, I'm feeling those similar symptoms in the ulnar nerve distribution. They can have weakness on exam, and remember it's intrinsic muscles that you're really testing. So abduction and adduction are ulnarly innervated. That would be weak, and you might even see some intrinsic muscle atrophy on exam. Treatment is pretty similar. Initially just avoidance of aggravating activities and trying splinting and extension at nighttime. We don't really inject the cubital tunnel as the nerve is so superficial here. Surgery is warranted if conservative management has failed. The final things we'll talk about in this articulate are trigger finger and Decker-Vein's tenosynovitis. These are very common conditions. Neither one is urgent, neither one is life-threatening, neither one has substantial long-term ramifications if you miss them, but they're very aggravating to patients, and you'll probably see them commonly, and we want you just to be familiar with what they are so you can recognize it if you see it someday. So first we'll start with trigger finger. Take a minute and read through this slide about what a trigger finger is. Most people with a trigger finger present because they say, "Doc, my finger gets stuck. I flex my finger and I can't get it extended again. I have to flick it open." And really, it's happening at the level of the A1 pulley, and it's very common when your finger is brought from flexion and you're trying to extend. The tendon gets locked in flexion. It's most common in the thumb, but really you can see it, and patients present with it happening in any finger. These are the risk factors, but again, it can happen in anyone. Cortisone injections really have a great success rate. They calm things down, calm down the inflammation, maybe let the swelling go down a little bit so there's not a discrepancy between the tendon and the pulley, and then the tendon will glide nicely and the triggering will stop. If injection doesn't work and it's really aggravating to the patient, because it can be pretty painful when they have to flick their finger out to get it extended when it's stuck in flexion, then you can do a 5-minute surgery where you release the A1 pulley and then the tendon can't get stuck. Now, Decker-Vein's tenosynovitis is a good review of anatomy for you. It's stenosing tenosynovitis of the first dorsal compartment. So you should remember from your good anatomy dissections and your text and your anatomy video that the first dorsal compartment is the abductor pollicis longus and the extensor pollicis brevis. Take a minute if you want to review and think in your mind, what are the other dorsal compartments? So here's a good thing for you to do. Extend your own thumb and just slightly radial deviate your wrist. Then you can look pretty nicely at the extensor tendons in your thumb. You can see where Decker-Vein's occurs, and you can also see your extensor pollicis longus. So now you know that this is where radial side of wrist pain occurs when people have Decker-Vein's tenosynovitis. Now put your thumb inside of your fingers and then ulnarly deviate your hand. I think if you do it hard enough, it hurts in anyone, and the location that it hurts is where people have really severe Decker-Vein's tenosynovitis. So that's actually called Finkelstein's test, and that really reproduces the pain in patients with Decker-Vein's tenosynovitis. Just to review the pathophysiology, the first dorsal compartment can be subdivided into two compartments. Often the extensor pollicis brevis is in its own compartment from the abductor pollicis longus. You can see this in up to 34% of the population. So the treatment is pretty similar to tendinitis or tendinosis of other tendons in the upper extremity. A lot of times we'll rest the tendons by splinting them. So a thumb spica splint is actually extending your thumb, because remember, flexing it and only deviating it really irritates these tendons. So if we extend the thumb slightly, this will rest them and hopefully help them calm down. A cortisone injection can be helpful, and if these things fail, what we do surgically is release the first dorsal compartment and the subcompartments so that the tendons aren't rubbing and compressed.